Good. All right. Fabian, I'm the Senior Director of Development for the Foundation Fighting Blindness. I live in Colorado. I used to live in Denver, just moved to Pagosa Springs, for those of you who might know where that is. It's really good to see everyone this morning on our Zoom community screen. Well, let's say I can't see you, but you can see me, but unless you're as blind as I am. And I hope everyone has been staying safe and healthy during this crazy virus that we're all dealing with, wearing our mask and staying as far away from everybody as we can during this time. So please stay safe and healthy. I want to welcome you to our 15th annual Safe Sight Saturday Symposium, sponsored by the Foundation Fighting Blindness. And we have several corporate sponsors. And plus we'll have several about 8 low vision services and adaptive technology vendors that will be on later in our session that are also sponsoring this event. We have, so far this morning, we had 68 RSVPs for our symposium today. And so I would equate that to usually when we have a physical event like the Rocky Mountain Lions Eye Institute past 3 years, usually 2 people came with everyone. You know, it's pretty much an average of 2. So we have about an equivalent of 136 people attending today. So welcome. Hope all of your family and friends, anyone that's impacted by retinal disease is watching today. And hi, I want to say hello to my wife, Claudia, and our aunt, Anna. Hi there. Good to have you with us this morning. So just so you know, the reason I can't see you too well is I have X-linked retinitis pigmentosa, which some of you might have as well. I've had genetic testing and found out I have the RPGR gene mutation. And that's really important because it makes you eligible for a clinical trial potentially to know what your gene mutation might be. So we'll be talking more about that. I started using a white cane in my early 40s, and then I started using a guide dog in my late 50s. So I still have my current guide dog from Guide Dogs for the Blind, Loot, and Parka, my retired guide. She's almost 14 years old. Let me introduce our partners before we get ready to introduce the program today. Chris Adams, our VP of Communications of Marketing and Communications is here. Chris, you want to say hello?
Good morning, everyone. Happy to help. If anyone has any issues, just let me know.
And we also have Marguerite Nicotano from Tampa, Florida. She's my virtual assistant, senior administrative assistant that's been working with me for about 10 years. So good to have you on, Marguerite, as well. Say hello, Marguerite. She must have went on mute. So here's our planned agenda for today. I'm going to go through this really quick because we want to get started here. So our first session will be Dr. Mark Mathias, who will be sharing our research update. Then what we'll have you do is submit your questions and answers and stuff, and I'll share about how to do that shortly. And we'll have our second session will be a question and answer session with a couple of retina docs, Dr. Mathias and Dr. Kimura from Colorado Retina, and we'll have Deneen Holloman from Applied Genetics Technology Corporation and Kelsey Ziegert from Informed DNA. Session number 3 will then start, well, session number 2 will start at about 10:50. Session number 3 will start at about 11:40. And that's when we'll have all of our low vision service vendors and adaptive technology vendors from the Colorado area that will be sharing about their services. And that way you can ask questions to them as well when you might need support in that area. And then our final session will be with Lindsay Blankenship, our Denver chapter president, who will share about local events happening soon. Now, if you'd like to ask a question, what I ask you to do, there's a Q&A button at the bottom of your Zoom screen. If you're using JAWS, you just tab down to that where you hear Q&A, and then you can type in your question and send it. And Chris will be monitoring those questions as they come in. And you can ask them, you can put them in anytime during the presentation, and we'll be talking about them during the question and answer portion. And then also, if you want to use an email, you can send to denver@blindness.org and I will see those questions and we will do our best to answer them. Any that we don't answer, we will get back to you sometime next week with an answer to your question. Chris, is there anything else we need to mention right now?
You are good.
Okay. How many we got in the room?
You are at 42.
All right. All right, let's get started. Dr. Mathias, Dr. Mark Mathias is a vitreoretinal specialist at the University of Colorado Eye Center, Rocky Mountain Lions Eye Institute. He's been a great partner with the Foundation Fighting Blindness over the past several years. I've been working with him for the past 3 years, and he's done several major types of surgeries that he deals with in his work. And so we're really pleased to have Dr. Mathias with us today. So please give us our update today, Dr. Mathias. Do we have Dr. Mathias? You might be on mute if you're trying to talk.
All right, can you hear me now?
Yeah, now we can hear you. Yeah, okay, there
sorry.
you
I was trying to say I could not unmute myself because the Zoom platform was blocking me from doing that. I think.
Oh, yeah, no problem. Please go ahead.
I got you.
No worries. So I'm going to share my screen now. See if I can do this and get us started here. All right. Well, thank you, everyone. Thanks so much, Richard, Chris, Foundation Fighting Blindness, for putting this excellent program together. I've had the pleasure of being invited to give this lecture, or a lecture discussion during these annual sessions that we've been doing for the past several years, and I really want to say thank you for putting this together and appreciate the opportunity to talk with you guys today. I know the COVID situation, as Richard said, certainly changes things, and sometimes these platforms, we've found that sometimes it lets people participate that couldn't come in person. So I know I can't see all of you today, but I'm sure there are a lot of familiar faces and hopefully some new faces in the audience today. But as Richard said, my name is Mark Mathias, and I'm one of the vitreoretinal specialists at University of Colorado Hospital. And I direct our retinal degeneration and ocular genetics center here. And I see I do both pediatric and adult retina. So I see kids from very young to very old. Today we're gonna kind of give a update on, research update on AMD, retinitis pigmentosa, and other inherited retinal diseases. Just a slide I have to put up. I don't have any financial disclosures, but certainly today this is going to be a pretty quick overview. We're certainly going to cover a lot of ground, so I kind of call this a review in the blink of an eye, because I have about 45 minutes to cover lots of updates here. I apologize in advance if I don't cover everything. Certainly there are going to be some things that we kind of skip over just for the sake of time. But certainly, and Richard kind of polled the audience in terms of what sort of diseases people wanted to hear about today, and not surprisingly, macular degeneration, retinitis pigmentosa, Leber congenital amaurosis, and Usher syndrome, as well as Stargardt, were kind of the most widely requested conditions to discuss. But we'll touch on choroideremia and X-linked retinoschisis today. I apologize, we're going to leave out a few others that I know were on the list, but for the sake of time, I'm not going to cover them, but happy to in the question and answer session if anyone has individual questions. So in terms of AMD, just everyone knows in the audience that we have dry macular degeneration and wet macular degeneration. And dry macular degeneration, we lose vision when we get these kind of deposits in the backs of the eyes that are waste products from cells called drusen that build up and eventually lead to cell death called geographic atrophy. And then other patients, about 15 to 20% of the time, lose their vision due to blood vessels that leak or bleed in the backs of the eyes called wet macular degeneration. first off, we're going to cover kind of a dry AMD update. And that's kind of been the biggest gorilla in the room because we certainly don't have, any really viable treatments at this point beyond recommending over-the-counter vitamins and lifestyle modifications like not smoking. But beyond that, it's really difficult for both us as physicians and you as patients to see you in the office when you get to a point you might be losing vision from dry macular degeneration, and there may not be a lot for us to do. So, the goals of the Foundation Fighting Blindness funding and all of us that are involved in research is to really try to find cures for these diseases, especially ones like dry macular degeneration. So our goals are going to be to prevent retinal cells from dying to begin with, so we can preserve vision. So maybe treating at an early stage if we can, and then alternatively, patients that have already lost vision. The question is do we have any options to restore sight in patients that have lost their vision, either with things like stem cells or even non-cell-based retinal regeneration techniques, which I'm not going to discuss a lot in dry macular degeneration, but I will in retinitis pigmentosa, and there may be some correlates there. And so, with dry macular degeneration, some of you, I had the slide last year, some of you, who have heard these research updates, just to kind of try to understand what some of these drugs or medications are looking at. There certainly seems to be a role of inflammation and the immune system of our body acting abnormally, specifically something called complement, which is a component of our immune system that can activate inflammation. And ultimately, when cells in the backs of the eyes get inflammation triggered, that can ultimately trigger cell damage and ultimately cell death that can result in vision loss within the retina. So some of these first medications that we've been looking at, at least in recent years, target the complement system. So this kind of abnormal inflammatory or immune response within the eye. Many of you may have remembered a couple of years ago, we had a drug called lampalizumab, which was an injection given that got all the way to a phase 3 trial. We were really excited about it, and then it didn't work. Well, work has continued on these similar medicines. We really think that they have a role in this process, and we're hoping that some of these newer medicines continue to show the encouraging results they have in earlier trials. So probably the biggest one right now is a drug called Zymura. It's made by a company called Iveric Bio, and it's an injection similar to what our patients with wet macular degeneration get. It's an injection to the vitreous that's given every month in patients who have already kind of started to develop some more advanced stages of macular degeneration that we call geographic atrophy, but hopefully, ideally haven't lost a lot of their vision yet. Maybe the cell loss is close to the center part of the vision, but not involving it quite yet. In October, so the updates I have for this drug, it's definitely an exciting one. In October of 2019, there was a phase 2 study where the results were announced, where there was about a 30% reduction in the rates of progression of geographic atrophy at 1 year compared to patients that weren't getting the treatment. And they just announced in June of 2020 that they followed those patients for even longer, up to 18 months. And at 18 months, those results seem to be sustained. So the drug seemed to have a lasting impact in terms of the reduction of progression of the dry macular degeneration. So that drug and company are now enrolling in a phase 3 trial, which we're anxiously awaiting, some results from that to see if it will validate what we saw in the earlier studies. So this could be a potential drug if the phase 3 studies show benefit of something that might be available if it works. And the FDA actually recently granted this fast track approval status, which means that there's very few options or limited treatments for this condition, and they really want to accelerate any drugs that are targeting or may have value in treating it. Another drug that has been in trials for a couple of years is a drug made by a company called Apellis. It doesn't have a name yet. It's called APL-2. It also is an intravitreal injection for dry macular degeneration that inhibits the complement system. And for that one, it's kind of similar to the Zymura phase 2 trial that showed about a 30% reduction in progression of the what we call geographic atrophy, the dry macular degeneration. And that also has an ongoing two ongoing phase 3 studies right now. And again, we kind of anxiously await the results of that to see whether these complement drugs will slow down the progression of dry macular degeneration. Like I said, we're all, as retinal physicians, very hopeful and think this does play a role, and we're continuing to look at the results of those. I had mentioned before, it'd be nice, I think I talked about this last year as well, but certainly it'd be nice if we had other things other than an injection of medication into the eye. Treatment burden coming into the office every month is certainly a challenge. So, there are other things. We've looked at eye drops in the past, but there's companies looking at oral pills now, and Alkeus Pharmaceuticals is one of those. And they're actually looking at an oral pill that they're doing studies for both dry macular degeneration and Stargardt disease, which share many similarities. In terms of how that drug works, essentially, what happens in dry macular degeneration, and Stargardt disease is that kind of the normal recycling process of the cells in the backs of the eyes stops. And we normally have, a form of vitamin A that is important for our rods and cones to be able to see, that's constantly kind of recycled throughout the visual cycle. And if that doesn't occur, then it can kind of build up as waste products. And similar to what we'd have like in a landfill here, and when we don't recycle and it builds up, and ultimately those can damage the cells of the eye and lead to cell loss and vision loss. So, that particular drug is basically like vitamin A that we take in our normal diet, but it's changed ever so slightly. That is all the good things in our body, but it doesn't build up as the damaging waste products of that recycling process that could damage the cells. So the hope is, by taking a pill once a day in dry macular degeneration, that perhaps that could prevent or slow down the damage that slowly occurs and leads to cell loss. So right now they're continuing actually a phase 3 trial right now for that. And we look forward to hearing the results of that over the coming year or so. I'm going to skip ahead a little bit. And again, I know I'm jumping around a little bit. I'll skip a few things, overall with some of these diseases, but I think those are some of the big things right now with dry macular degeneration on the medication side. And then we'll talk a little bit about stem cells, which I know people like hearing about, because once you've lost your vision, those drugs that I was talking about before certainly may not, help those patients. So we want to look at ways that perhaps we could regenerate the cells in the backs of the eye so you are able to see. A little bit about stem cells, and one question is kind of what cells do we replace? We have multiple layers in the back of the eye, and many of you might recognize what we call photoreceptors, which are the rods and cones, the light sensitive parts of our cells. But right beneath that or below that, there's a pigmented layer that we call the retinal pigment epithelium that kind of provides support to the rod and cone cells. So if the RPE, or retinal pigment epithelium, gets damaged or it dies off, then ultimately the rods and cones do as well, and we lose our vision. So both degenerate in macular degeneration. And so the question is, do we replace one of those, both of those? And that's what different people are looking at. What types of cells we can use for stem cells certainly, is a question. And there are some validated what we call embryonic stem cell lines that don't involve fetuses currently, but are derived from a fetus cell line. Some people have ethical concerns about that, and certainly there are, and some people or some groups are using that. The other option is a cell called an induced pluripotent stem cell, or iPSC, and those are kind of neat. I know we've talked about those over the years as well. It is the idea behind that is we have cells within our body that in the right laboratory environment, we can take a biopsy of those cells, like something from the skin of a person, and kind of in the lab convert that into a stem cell. And we can actually from that ultimately grow retinal cells that can potentially be transplanted. So that's kind of exciting because we don't have any ethical concerns with that. And we can also potentially, treat someone with their own cells back in their body. And so many people have been looking at that. Skip over that a little bit. That's just, and so, in terms of stem cells, what to implant kind of comes, or when to implant, like what type of cells to implant. Do we implant them when they're kind of immature stem cells, or when they're completely mature, like already a cone cell, or, just almost a cone, a rod or cone cell? Is it maybe better to implant that type of cell? We're not really sure, but different groups are looking at different types of stem cells. It might be better to implant them when they're a little bit immature, so they have the potential to kind of form connections and the things they need to do within the retina. That's one of the first groups to start this all was a group in Southern California, out of Los Angeles, a group out of UCLA, and in 2012 initially they had kind of reported on transplantation of the retinal pigment epithelium as what we call cell suspension. So you basically take those retinal pigment epithelial cells and you suspend them in some fluid in a syringe, and you can inject those underneath the retina. One concern there is that the retinal pigment epithelium is kind of a single layer of cells. So if we have a suspension of all those cells and we inject it, they might not necessarily kind of layer out evenly where they would need to in the area of geographic atrophy. And so potentially, some groups are looking at other ways, maybe growing sheets of cells that we can transplant that are already one cell layer thick and more imitates the normal anatomy of the back of the eye. Groups are still looking at cell suspensions though, because it's much easier to get in the eye. This is kind of a company that's working on a really innovative way to get the stem cells into the eye, the retinal pigment epithelial cells, and the company is called Lineage Cell Therapeutics, and they have a product that's called OP Regen. That's just the name of their product, and it's retinal pigment epithelial cells, but instead of actually doing a surgery where you have to go inside the eye and inject it underneath the retina from the inside of the eye, they actually have partnered with another company that's created a different, what we call delivery tool, a different way to put stem cells and or medicines into the eye, because when we talk about gene therapy, this is another delivery method that's very, very innovative and may have some advantages in terms of minimizing trauma and damage to the retina when we try to put medications or stem cells there. But it's called suprachoroidal delivery. So you make a small little incision on the white part of the eye, and there's a tiny little catheter that you thread all the way back to the back of the retina, to the macula, where you'd like those stem cells to go. And then you can inject them underneath the retina. And that company that's, Lineage Cell Therapeutics, that's just a kind of a magnified view of where that little catheter can kind of go through the back wall of the eye underneath the retina without actually creating a hole or a puncture through the retina itself. So there may be less trauma there, and kind of put the stem cells there. So that company has a phase 1 or 2 study, and in May of 2020, they released some of their interim results, which were encouraging, which showed some improvement in visual acuity, some improvement in reading speed. So they kind of tried to measure things that might have a meaningful outcome or be more meaningful to patients. So certainly reading is something that's important to all of us. So some of those patients had reported improved ability to read. And then they looked at the geographic atrophy, the cell loss that occurred, and it seemed to slow down in the patients that were treated. So certainly, encouraging with this stem cell product, and we'll look forward to, as those studies progress into phase 2 and 3 studies potentially. Now, one of the questions is, can we create a single layer of cells, like I said, with the retinal pigment epithelium? And, like I said, the actual cell, the actual layer of the retinal pigment epithelium is only one cell layer thick. So many of the earlier studies with some of the cell suspensions have shown they kind of clump together and don't really layer out very nicely. So some groups are looking at creating kind of single layers of cells on what we call a scaffold, which is basically a sheet of something, whether it's there's different what we call biocompatible materials, which means that they don't cause any problem when implanted in the body, that can be created in a super thin sheet, and on top of that you can grow these retinal cells and then transplant them under the retina. So one of the first groups to report on that, and I showed this photograph last year, was a group in Southern California at USC, and they'd been able to transplant a handful of humans. They transplanted it attempted 5 patients, but ultimately transplanted 4. But it was really neat, and they showed this really cool photograph on the cover of Science and Translational Medicine magazine, and definitely a really definitely pushing progress forward in this. To be able to kind of do this in humans is really amazing, to be able to do that. Lots of other groups working on this. This is in March of 2018, a group in London in the UK that they actually treated patients with wet macular degeneration here. So I wanted to mention that some of these stem cell patches are being looked at wet macular degeneration as well. This is a group led by a researcher named Peter Coffey out of the UK. And again, this is kind of what we call a scaffold with these RPE cells on it. So that was, very interesting, and that we're able to kind of show these groups working on that. There is a group at the National Eye Institute that's working on a similar technology, a similar stem cell transplant. In this case, though, I mentioned that there's, the stem cells have to be grown on what we call a scaffold, and many times that scaffold doesn't degrade within the retina; it stays there. But there are what we call biodegradable scaffolds, so you can actually create something that's like a sheet that you can grow these RPE cells on, but it ultimately kind of goes away within the eye, and that could be beneficial potentially, because that little sheet of sometimes it's polyester or a type of plastic polymer, it may not allow, if it doesn't degrade, it may not fully allow the blood supply and other things to get across, and it could impede things. So if you have something that goes away on its own and just leaves the stem cells there, that could be a good option. And so they're launching their first human study here in 2020 now with that technology.
About 20 minutes left.
Okay, great. I'll keep going. Thanks. And then the question is, can we go beyond the retinal pigment epithelium? Can we integrate photoreceptors into the retina along with the RPE? There's several groups working on this quote unquote combined patch. David Gamm at University of Wisconsin, the University of Iowa, and we actually are working on it here at University of Colorado. So I don't have any information on any of their results yet, but I can kind of share some of ours here from some of ours. We have our stem cell center here is called Cell Site. We don't have any human studies yet, but we're doing preclinical trials on a stem cell patch. We can grow in the lab mini retinas from your own stem cells. They're called retinal organoids. And we know that those respond to light and they have functional rod and cone cells. But our goal is to kind of combine those rod and cone cells with the RPE and implant them under the retina. So we've actually done some early studies on pigs that have a form of retinitis pigmentosa and can't see, and we've been able to implant these scaffolds along with the rods and cones underneath the retina, and we're evaluating how these rods and cones might function and stay within the eye. So we continue to move forward with that. In terms of wet macular degeneration, we've talked a lot about intravitreal injections before. We know that we have several medicines that last 1 or 2 months. But certainly it would be nice that if we had medicines that last longer, medicines that work better, and medicine, potentially the ability to restore vision once sight is lost. We did have a medicine that was FDA approved in October of last year. Some of you may have heard of that. It's called Beovu. That was designed to last 12 weeks rather than just 1 to 2 months. So that was exciting. But there have been a few safety concerns after it's been approved, which has limited its use by many retinal physicians. And so many of us are kind of waiting a little bit to gather a little bit more information. Some patients have developed some inflammation in the eyes that has been a problem. So until we have a little more information, some of us haven't been using it, but that's only been in a very, very, very small percentage of people. So in many people, it works really, really well. There's a couple of different what we call anti-VEGF medications. So they're similar to the medicines that we have, like Avastin, Lucentis, and Eylea. There's a drug called Abicipar Pegol that I talked about last year. I just put that in there because there was concerns about inflammation with that drug as well. And the FDA actually 2 months ago decided that they didn't want to approve it because of those concerns. But that's not all bad news, because there's many other drugs that are exciting. And there's another one that's being developed by a company called Opthea, and they are planning a phase 3 trial where they combine this drug with one of the drugs already called Lucentis to see if it can last longer. Another drug called faricimab, which continues in phase 3 studies, and that's designed to actually last potentially up to 4 months, 16 weeks. So we look forward to see whether that what benefit that can have. Now, can we make drugs last longer? And many of you have heard this before, like a drug called Lucentis that we normally get injected every 4 months. That company that develops that has developed an implantable port, a little device that's implanted within the eye that you can refill periodically. And that actually has been in a phase 3 study whose results were just announced at ASRS, and they actually found that 98% of patients were able to go greater than 6 months without needing another injection. So that's really exciting. That may allow us to reduce the treatment burden. So we will await to see how that progresses in terms of FDA approval, but that may be an option for some patients. Another way might be gene therapy for macular degeneration, where we can actually potentially put a gene in the eye that can create a drug like Lucentis or Eylea. And there's a couple of companies that are working on that. One is RegenX Bio, and they updated us in April of 2020 with their phase 1 to 2 trial. They have 42 patients enrolled, and 6 patients have reached the 2-year mark. And about 3/4 of patients at the high dose, in the high dose group remained injection free at 9 months. So that's actually very exciting too. That could reduce the treatment burden for patients. The second company is called Adverum Biotechnologies, and they created a gene therapy that makes Eylea inside the eye itself. And they have an ongoing phase 1 trial, and they just updated us in May of 2020 that it seems to have long durability, and none of the first patients needed any injections at 1 year in the first group. So it seemed to be sustained, where you just get this one treatment, one injection. It's done with a surgery, but those patients didn't need to get future injections up to a year. So I'm going to switch gears a little bit and transition to retinitis pigmentosa, Leber congenital amaurosis, and Usher, which I kind of combine, all into the same here. But many of us know that, exciting, a few years back, we had the first gene therapy approved for a gene called RPE65. We've talked a lot about that in the past, but we're going to talk about some new things that are being looked at. Many of you know that we have diseases that the inheritance of the diseases. We've mentioned X-linked, as Richard's talked about a little bit, but I'm going to mention recessive disease and dominant disease. And recessive disease, where you have 2 abnormal copies of the protein, we can do what's called gene augmentation, or replace the gene. And that's what most of the gene therapies are looking at. Some dominant diseases are a little more complicated. Sometimes these might require what are called gene editing with CRISPR, which we also have talked about in the past. But we are moving towards potentially being able to treat some dominant types of retinitis pigmentosa, which is exciting. The viral vectors, I'm kind of going to skip over this for the sake of time here, just so I can kind of talk about the ways that we deliver the drugs, which can be either with an intravitreal injection or a subretinal injection, where you actually require a surgery as opposed to an office-based procedure. many of the gene therapies have looked at subretinal injections, and that's the preferred method. But there actually are companies now that are looking at just doing office-based intravitreal injections for gene therapy, and I'll mention that. We also, mentioned here before about the suprachoroidal technique with the stem cells before, and that is being looked at to deliver gene therapy as well, potentially. This is just a list that I came up with, just kind of reviewing everything of all of the current gene therapy trials in inherited retinal disease. You'll see there are a lot of ones that cover, retinitis pigmentosa, Leber congenital amaurosis, and Usher. So the majority of those, I think we have 11 on there that target just those diseases. So a little update on X-linked RP gene therapy. Nightstar in March 2020 published their initial results from their phase 1 study, and they had 18 patients. They found it was safe, and some of those patients were having some improvement in their visual field, which was encouraging. AGTC in February 2020 announced they completed enrollment of their 2 highest dose groups in their X-linked retinitis pigmentosa trial. So we're excited to see how those patients do. There is a company called 4DMT that is looking at intravitreal gene therapy for X-linked RP. So instead of requiring a surgery, you can do it as an office-based procedure like we do for macular degeneration. And they've optimized in the lab a viral vector that can be given as an intravitreal injection. And the first patient for that study is planned to be treated in the next month or so. So we're looking forward to that. There's a company called ProQR, which is looking at these tiny little bits of DNA. It still is a gene therapy. It's called an antisense oligonucleotide, a big long name. You don't really need to remember that it's a little piece of DNA that can modify genes and a gene expression in a certain way. And it gives us a little different way to treat some diseases, including some dominant types of retinitis pigmentosa. So they currently have 3 drugs that they're evaluating: one for Leber congenital amaurosis for a gene called CEP290, one for Usher syndrome, a gene called USH2A, and one for retinitis pigmentosa dominant form with a gene called rhodopsin. So that's exciting that we can see some dominant diseases potentially treated. The one that's furthest along is the Leber congenital amaurosis gene therapy for CEP290, and they actually have an ongoing phase 3 study called Illuminate that they've gone to, but they did in October 2019 release the phase 2 studies, and they said, "We reported today," and I'm quoting, "that patients receiving the drug had a clinically meaningful improvement in vision, and in some cases the patient's vision improved to a level that could be deemed life-changing. This is very encouraging for the LCA10 community and the inherited retinal disease community as a whole." So we definitely look forward to see how that drug progresses for that type of Leber congenital amaurosis. And for the USH2A or Usher syndrome gene therapy, in March 2020, they've announced that 25% of patients experience significant improvement with that drug, but they're actually going to start expanding to an increasing dose and enrolling a certain type of patient that they feel is most likely to respond to the drug. So we'll see if we get good results with that, but we're encouraged by that. For future trials for Leber congenital amaurosis, there is a gene called CRB1 that is very common in LCA, and there's a group in the Netherlands at Leiden University that, while they're not planning a gene therapy trial in the imminent future like this year, they are moving forward and planning that in the next couple of years, and they're aiming for 2023 that they'll have a gene therapy trial for that gene, which is exciting. In terms of stem cells for retinitis pigmentosa, the 2 big companies that are based here in the US and California, J-Site, which is an intravitreal injection. In July of 2020, they announced some interim results of their phase 2 trial, and they showed about a 16-letter improvement in the high-dose treatment group, which is very encouraging. Reneuron, the other stem cell company for retinitis pigmentosa that's based in Boston, that one's a subretinal injection, so it requires a surgery, and they still have an ongoing phase 2 study. I don't have any new updates on that one yet, but we're certainly encouraged by some of the initial results both of these groups have shown. We mentioned before, can we go beyond beyond just rods and cones, can we replace both of them, which we might need to in retinitis pigmentosa. So I mentioned a few groups here when I was talking about dry macular degeneration, us here and a couple of groups in Wisconsin and Iowa around the country that are working similarly on that. Other therapies that, I'm going to skip over optogenetics, but there was this really neat article here that was published just in June of 2020 in the journal Nature Nanotechnology, and this was describing subretinally injected, it's a big long thing, but semi-conducting nanoparticles that rescue vision in a rat model of retinal dystrophy. So they had some rats that had a form of retinitis pigmentosa, and they were able to inject a nanoparticle, which is basically just a tiny, tiny little particle. But in this case, it's a semiconductor. So that means it's able to conduct electricity. So in this case, they are able to integrate with the retinal cells and in response to light, create some electrical signal, which the rods and cones normally do. But a rat or a patient with retinitis pigmentosa, is not able to do that. So this may be a different way outside of stem cells to bring vision back in someone with retinitis pigmentosa. So that's kind of exciting to see some different work on that. Now, in terms of Stargardt disease, I mentioned when we were talking about dry macular degeneration that Stargardt is quite similar to that. The same company called Alkeus Pharmaceuticals that's developing an oral pill for dry macular degeneration also has a phase 2 study of that modified vitamin A molecule that they're developing for Stargardt and have been enrolling patients for that. And we're looking forward to the results of that study. There also is another company called Acusella that has an oral pill that they're developing for Stargardt disease. It modulates a protein called RPE65. You may recognize that from something that can cause retinitis pigmentosa there, but they have an ongoing phase 3 study. And in February of 2020, they announced that they'd reached 65% enrollment of that. So they haven't, I don't have any updates on the results of that study, but definitely, we have kind of 2 companies that have oral pills here for Stargardt disease that they're in clinical trials right now. Another drug that I mentioned for dry macular degeneration that was an intravitreal injection called Zymura that modifies the complement system or kind of inflammation and immune response within the eye. That also is being looked at for Stargardt disease, and there's an ongoing phase 2 study with that. So I mentioned before that seemed to have really encouraging results in dry macular degeneration. So certainly with Stargardt disease, we look forward to those results. In terms of gene therapy for Stargardt, there was a company, Oxford Biomedica, that had partnered with a company called Sanofi that for the past 6 to 7 years had been developing a gene therapy both for Stargardt disease and for Usher syndrome. Recently, a couple of months ago, that company announced that they weren't going to be pursuing that any further, but it's not all is lost because AJTC has announced recently that they've developed a really novel, kind of innovative way to deliver the Stargardt gene therapy that they're pursuing. And it's what's called a dual vector system, where you kind of have two viruses, or you kind of split the gene in half, essentially. The gene that causes Stargardt is very, very large, and it can't be put into one of our normal gene therapy viral vectors. So they've kind of split it in 2, and they're going to try to develop that to treat Stargardt. So we're really looking forward to that. X-linked retinoschisis. I don't have a big update on that. In terms of the gene therapy, for that, we only have one group that's continuing to pursue that, but definitely pursuing it very, wholeheartedly here. And that's the group at the National Eye Institute, and they're continuing to work on their gene therapy trial. They've been gene therapy
Can you hear me,
trial,
Mark?
and yeah.
Okay, sorry.
Can you hear me?
Yeah, sorry,
Okay.
I got muted, and so you got like 2 minutes to wrap up. Sorry,
Yeah, I know that. I'm actually
I
almost done. I got
had a
10,
technical
10:45, so
problem.
that's okay. So, we don't have a big update on X-linked retinoschisis, but the good news is we still have a group that's actively, pursuing gene therapy for retinoschisis. Choroideremia, not a huge update on that one either, but definitely, gene therapy companies that are really aggressively pursuing this as well. Nightstar is the company that's the furthest along in an ongoing phase 3 study that we'll await the results of. But there are other companies that are now pursuing this. Spark Therapeutics, who developed the RP65 gene therapy, and then 4DMT, which I mentioned before, is developing an intravitreal gene therapy, are both going to be pursuing choroideremia potentially. So I think I ended pretty much on time, Richard, because that's actually everything I had. So I think I'm going to end here because we wanted to give ample time for hopefully a very interactive question and answer session, both to kind of ask questions about what we've talked about here. And also, I know there are several in the audience that might have questions about some things we didn't cover today, and potentially some other retinal conditions, and we'd be happy to answer questions on those as well. So I'll end there, Richard, and let you guys take over.
Yeah, thank you, Mark. Thank you, Dr. Matthias. That was great. You covered so much ground. That's wonderful. 45 minutes, that's a lot to cover. So please use the Q&A button to send in your questions. And we're going to take a 5-minute break here to get the panelists ready for the question and answer session coming up at 10:50, thereabouts. And so just send in your questions about any eye disease that you're concerned about, and we'll do our best to answer your questions shortly. So be back here in about 5 minutes. Stay tuned. So Chris, I don't know where we are are we in a panelist room or where are we at?
You are good, so everyone will start unmuting themselves. That.
Yeah, so now we have the 4 panelists, Dr. Matthias, Dr. Kimura, Dr. Holloman, and Kelsey Ziegler. Are you all 4 here? Let me know when we're back, Chris. You got the slide up for the next session? Start our question and answer period. We have, we understand 9 questions that have come in via the Q&A feature on your Zoom screen. So if you have a question, just go to the Q&A, type in your question and hit send. And Chris will be monitoring those. And one of the questions that came up was, will this session be recorded? And the answer is yes. This session is being recorded. So there will be a link sent out next week to everybody who attended. And we might even send it to the entire Colorado group so anybody can watch that didn't get a chance to participate today. So now we're ready to start our question and answer session on the research and related topics. And we have our panelists with us today. Very great to have Dr. Matthias again. And thanks for your presentation, Dr. Matthias, covering so many areas of disease and the different clinical trials that are going on right now. It's if we'd have done this session 10 years ago, we'd have had about 2 or 3 possible trials to even talk about. So it would have been a much shorter Zoom presentation. But today we have so much going on. It's really exciting with I think it's over 300 genes have been discovered. Kelsey will be able to update us on that. But there's just so much that's been discovered. We have over 40 human clinical trials going on around the world, plus many, many more that others are involved in. So we also have Dr. Alan Kimura, who is with Colorado Retina Associates and has been one of our presenters for many years with the Colorado chapter. Thank you, Dr. Kimura, for being here today. We also have Dr. Deneen Holloman with Applied Genetics Technology Corporation, who will be sharing about human clinical trials that are going on that they're performing today and having some exciting success. And we have Kelsey Ziegler with Inform DNA. We'll be talking about genetic testing and My Retina Tracker. If you want to know how to get that accomplished, she will be handling that. So Chris, all right, what is one of the first questions?
Sure. So one of the first questions that we have this morning is for Dr. Mateus and Kimura. The question is, do you have an estimate of how many citizens in Colorado and or the US who have choroideremia, RP, AMD, or even other retinal diseases? And just wondering if that is information that is tracked and made available.
Yeah, I'll take that first. I mean, yeah, certainly we do have very good estimates of the numbers of patients that have many of these diseases. For example, choroideremia, is the estimate somewhere between 1 in 50 to 1 in 100,000 patients people have choroideremia. For retinitis pigmentosa, that number is much higher. It's somewhere around 1 in 3,500 to 1 in 5,000. And for many of our other inherited retinal diseases and AMD, we have good estimates of those numbers. In terms of tracking, that's definitely a different, quote unquote tracking. That's certainly a different story. I know Kelsey's going to talk about my retina tracker and that sort of thing, and genetic testing here. And certainly that's we don't have great databases ultimately of all of these, especially kind of the more rare inherited retinal diseases. But my retina tracker is a really good initiative to really try to compile that within the United States. And Alan, Dr. Murray, do you have anything to add to that? Or
yeah, no. So I'm hoping that in this new era, or first, I want to give you a big hand, Mark, for having a near impossible job of covering all these studies that are going on. So thank you very much for doing that. That was a really good question. And so one of the changes is this, the genetic testing is just really expanding. I think a big reason is because of the funding from external sources, including FFB, that makes the cost very affordable, meaning free. So we're going to get better estimates. So a lot of diseases that we thought, you have this or that, we may now find like, oh, you have choroideremia instead of just garden variety RP. So maybe I'll hand it off to Kelsey and she can tell us more about how genetic testing is changing our estimates.
Yeah, let me before Kelsey, you start. Kelsey, would you go ahead and introduce yourself? I'm sorry, I forgot to give you the opportunity to introduce yourself and your slides, and then I'll have Dr. Holloman do that as well after you speak. Kelsey, go ahead.
Sure. Let me pull that up real quick. Can you hear me okay, first of all?
Yes.
Okay. Okay, so I'm Kelsey Zegar. I'm a genetic counselor currently at Informed DNA. Previously had the pleasure, though, of working with Dr. Mathias and Dr. Kimura through Children's Hospital Colorado and the university. And so Informed DNA now currently is a telephone-based genetic counseling service. We were telephone-based even before this pandemic happened. So fortunately, we've been able to kind of keep going, keep talking to everybody about their genetic test results. But that's really our biggest role with this genetic testing for retinal diseases, is to kind of interpret those results and explain them to folks after their testing is completed. So if you are interested in genetic counseling, that option is available to everyone who goes through testing through the Foundation Fighting Blindness, my retina tracker genetic testing program. But if you have had genetic testing through any other way, through a different lab or through a different clinic, we're happy to talk to you about those results as well. So I just wanted to link up our website and phone number in case you have any questions for us. Yeah, I guess that's that's me.
All right, anything to add to what Dr. Matthias and Kamura were talking about, the number of people affected in Colorado or nationally?
Yeah, well, I think the point I wanted to build on is that it is true that as we learn more about the genetic type of inherited retinal disease that people have, sometimes that is changing from what it looks like clinically. And so that's helping our understanding a lot better too. Where it may look like one type of retinal disease, and Dr. Kimura gave the example of retinitis pigmentosa, where the genetic testing actually comes back positive for choroideremia. And that's a real life example that's happened a few times already. So that's helping us get a better grip on all the subtypes, I think, of inherited retinal disease.
Great, great. Thank you, Kelsey. And I can add as well that our analysis shows that about 10 million Americans are affected by AMD and orphan inherited retinal diseases. About 200,000 of those are the orphan type nationally. Of course, millions more around the world. But we found or estimate in Colorado that over 165,000 Coloradans are impacted by these diseases. So that kind of gives you a number there. Okay, let me have Dr. Deneen Holloman. Would you introduce yourself and AGTC, and then we'll go back into our questions.
Sure. Yes, hello everyone. I'm Deneen Holloman, PhD. I am Director of Clinical Research and Medical Affairs at AGTC, and I will go ahead and share my screen now. And hopefully you all can see that.
Sounds like it.
Yes.
Okay, good. All right, so thank you for having me this morning. Just to give you a brief outline of what AGTC is working on. Of course, Dr. Matthias did provide an excellent overview of our programs, but we're all about creating value for patients. We currently, as was mentioned, have an XLRP clinical trial program that is only enrolling male patients with X-linked retinitis pigmentosa. We are in our phase 1/2 stage of the program, and thus far we have reported stable visual function for those male patients that have been peripherally dosed at 6 months, and as well as improved visual function for those who were centrally dosed at 6 months, and this is with a subretinal injection. We actually just announced about a week and a half ago that we'll be expanding some patients in our phase 1/2 program. So now is a good time to reach out and inquire about any questions you may have about clinical trials. At the bottom of the screen, you can see the email address is advocacy@agtc.com. As well, we announced recently that we'll be moving forward with our phase 2/3 clinical trial program, where we'll be expanding the number of patients in that particular clinical trial. So we are showing really good early evidence of biological activity with our particular drug that's delivered subretinally, also in achromatopsia trials. And we also have a very broad pipeline for indications in otology as well as CNS. So we're excited about the next stage. I do want to mention that if you are interested in clinical trials, certainly you can take advantage of some of the free genetic testing that may occur through FFB. Certainly we would also encourage all patients out there to make sure that they get appropriate medical records. Electronic copies are always preferred for your genetic results, as well as your medical history and ophthalmology exams. So all of those things are important. If you would like to participate, just to have those records on hand would be great. So thank you for having me again, and I welcome any questions.
Thank you, Dr. Holloman. That's great. That's great. Hey, I'll answer a question, or direct a question that I just saw in my email. This person has X-linked RP and also has the RPGR diagnosed. So this person that sent that in, I think Dr. Holloman just gave you a good opportunity to be part of their trial. So you should investigate contacting them directly to see if you could be possibly. Are you going into phase 3 anytime soon, Dr. Holloman?
Well, we announced recently that we'll be planning that sometime at the next year. But right now, the phase 1/2 program is going to be expanded to include some additional patients and the treatment arms.
Okay, well then there's an opportunity to get involved right now. So please contact Applied Genetics Technology, and you can do that through that information that she just shared, or go to clinicaltrials.gov and looking up XLRP and the AGTC trial. So is that right, Dr. Holloman?
That is correct. And again, it's advocacy@agtc.com. I can certainly type it into the chat here.
Okay, great. Go ahead and do that, and that way everybody will have that who would like to potentially participate in that trial. And he also asked, what about seeing a retinal specialist? How often should he see a retinal specialist for his eye disease? Dr. Kimura, would you like to answer that?
These are progressive diseases. So again, we want to try to catch things early in life if possible. So it kind of depends maybe where you are in the life course of that disease. Certainly earlier we might be following you more closely. If you reach a stage where maybe a lot of damage has occurred and perhaps there may not be that much change that's noticeable to a patient, maybe that interval could be expanded.
Okay, great. Chris, back to you.
Sure. Another question, I think we get this a lot, is that for the panel, do you feel that the current trials or treatments mentioned in the FDA process will be delayed or impacted by the current emphasis on COVID, or is it just everything's running on separate tracks?
Well, I will say at AGTC, we are working very hard to try to figure out ways around it. We decided that we may need to go mobile. And so we have at least tried to come up with some opportunities to have a mobile van for those who are currently involved in our trials to get some of their assessments, especially at hospitals that are really significantly impacted by COVID, which some hospitals are. We're also finding that some academic centers are actually seeing patients right now and have started to kind of open up a bit. So I think it really just depends on the institution, but we certainly are realizing that we do need to do a little bit more to try to work around some of the restrictions that are out there.
Yeah, I'd just echo that and say, I mean, the COVID situation is very different in many cities and many states around the country in terms of, how many affected people there are and the severity. So, most clinical trials are run at multiple sites around the country. And so that can be a challenge for companies like AGTC, where we may have several centers whose hospitals have reopened and are seeing patients for studies and can start enrolling again, and certain hospitals that might not be able to do that. So there are challenges to work around with that. And, as she mentioned as well, just, some patients come from far away. They just have, they're concerned about traveling, especially the patients that are already enrolled in the study for follow-up. So I think going mobile is maybe a good thing that many may have to consider. So.
Yeah, I think from a global perspective, it affects so many aspects of patient, clinical research. So one is just site initiation, where the company needs to evaluate dozens of different factors at the actual site. So the site visits, of course, are made more difficult because we're having the physical distance. Say once you're in the trial, so if it's an observational trial where you're just gathering natural history, perhaps those visits might be triaged to something you can put off a bit. But if you're in an interventional trial where you're receiving drug as per protocol on a very strict schedule, that's where the challenge comes in for the data, because you're missing data points. I'm sure Deneen can go on speak eloquently. That's always a problem when you're trying to analyze the results, or let alone submit to the FDA. So this is a global problem for research across everything besides eye disease. Particularly a lot of cancer trials and other things. So as Mark says, all pandemics are local, so we want to make sure that it's deemed safe for the patient to come in. So some patients might not want to come into a hospital or a private practice setting unless they feel very comfortable. They have to weigh the risk to their own health versus the public health crisis. So yeah, it's something on our minds all the time in this pandemic.
All right, next
Perfect.
question.
Yeah, so absolutely. So we have a question in that, can you briefly explain myopic degeneration versus AMD, and are the AMD treatments applicable?
Dr. Matthias?
Yeah, I mean, there are definitely some similarities, but they are different. One challenge with myopic degeneration is that the layers of the back wall of the eye are extremely thin, and that likely is a big contributor to the degenerative process. And so there's an anatomic kind of component that is difficult to completely correlate, as opposed to maybe an abnormal immune response and these things called drusen that build up in the backs of the eyes and lead to damage. There certainly is some correlation with wet macular degeneration, where we can see some, many patients that have myopic degeneration develop, blood vessel growths that leak and bleed underneath the retina and require the same therapies that wet macular degeneration patients have. So, certainly the treatments that are applicable for wet macular degeneration are would correlate with someone who has a similar process with myopic degeneration. But, it's difficult to really, to know whether any of the drugs like that target what's called the complement system, like I talked about, would really be applicable in myopic degeneration. I think the process is a little bit different for sure. The challenges of using stem cells in an eye with myopic degeneration, just the layers of the wall of the eye being really thin, can definitely create a surgical challenge in terms of introducing those stem cells. But definitely, the stem cell therapy could be applicable there. Alan, do you have any comments on that?
Yeah, maybe just I'll add maybe a little different take. So myopia, there's a lot of different ways to end up nearsighted, and Kelsey maybe can add on a little bit. Maybe there's a couple candidate genes maybe found in different populations that might increase your risk, but as far as I know, it's not like a single base pair can give you that. It's also interesting in some of the more severe forms of RP, maybe like X-linked RP. Yeah, the nearsightedness is a component of the poor vision. Just in kind of what we might call a more general population level thing, just sustained near effort of reading can induce myopia. So there's actually studies on that for people, I think in law school and medical school, there's periods where for a year or two you're doing nothing but reading. And they show that your nearsightedness increases. There's also increasing kind of talk about kids growing up from the minute they're born looking at their phone. So that actually might increase your myopia. So there's environmental behavioral aspects to like sustained near effort. So I know a lot of my optometry colleagues that are young mothers, they have strict limits on screen time. They say you get outside and play. And there's some soft evidence that's building saying, yeah, if you're outdoors, maybe your progression of myopia might be a little less. So this is a field that's just evolving because we really haven't studied it that much.
Well, great. Thank you guys for that. I think that's a good summary for that particular question. I have one that came in just now. Does anybody know anything about the for RPPDE6 gene mutation? Is there any trial update on that? Does anybody know?
I don't have a trial update on that. I don't know if
off the top of my head, I don't know.
Yeah, okay, no problem. I'll get back with them on that question because I know the Foundation Fighting Blindness held a meeting recently, well, several months ago now, when people were meeting last fall actually, and they're working on putting together a strategy for that. So I think it's still in motion for that particular, and there's no trial set yet. There is a doctor in England that is working on that. So does anybody else have any information on that, or will not, we'll move on. Okay, Chris, I think I heard a chat question hit the board. Is that right?
Yeah, so one of the questions that did hit chat, let me go to that one. Are there any RP treatments readily made available to the public for those with RP?
LCA. That's about it.
I'm not sure if that's my question. From a genetic standpoint, there's one gene that has an approved gene therapy that is made available to the public, and that's for the RPE65 gene called Luxturna. I know we've talked a lot about that since that was approved. As far as other treatments, though, I'd have to defer to Dr. Mathias and Dr. Kimura.
Yeah, I mean, in terms of publicly available treatment, I mean, in terms of, an FDA approved treatment that anyone in the public would be eligible for if they had, 2 mutations in the RP65 gene, that would be it. The other ones that are in trials, obviously any clinical trial has, inclusion and exclusion criteria. So you as a member of the public, if you qualified for a trial, could participate in that. But that's what I would say about that.
Yeah, it really goes to the FDA.
Go ahead, Doc. Yeah.
For all this research, right? Starts preclinical, phase 1 safety, phase 2 kind of dosing, little safety, phase 3. Does it really work in a larger population? And as Denise knows, the holy grail is if you can go through that funnel of just progressively higher odds against you, you get a drug that's safe and effective, you get FDA marketing for approval, as Mark said, then it has very specific label indications for the use of that. So that's how it gets to the public after this massively long and expensive process of approval.
Yeah, I'll just add to that and say that there are a lot of trials going on today for a lot of different diseases. And the best way I feel for you to find out if there's something out there where there might be an actual clinical trial going on for your specific gene mutation is to go to clinicaltrials.gov and enter that gene mutation, like RPGR or XLRP or whatever your disease might be, and see what comes up. You'll be surprised. That'd be the best place to look. And then you want to make sure it's FDA approved trial if something's going on, because there's a lot of sham trials going on that you don't want to get involved with. So be careful with that. You can always send us an email if you found something and say, what do you think about this? And we'll let you know. So that's what I would suggest. And then the other thing is we have Kelsey Siegert here because if you've not had genetic testing done yet, or, because the Foundation Fighting Blindness is providing it free of charge today if you've not been tested since 2016. If you've been tested since then it probably wouldn't apply for our free test, but we could certainly help you get a discount in some form or fashion. So anyway, please check with us. And check with Kelsey Ziegert and Inform DNA, and through the foundation website, you'll find more information about that. What's the next question?
Richard, that's actually, yeah, actually, Richard, that was a great segue into the question I was about to ask for Kelsey. Kelsey, can you walk through the process one would go through to get genetic testing from the foundation, and how we engage with Inform DNA with results? Because basically, you know, the question here is that if my doctor reviews the genetic results already, should I still engage with Inform DNA? And if so, what are those costs, if any?
Sure, those are great questions. Actually, let me pull up my one other slide that I have. So this is kind of an overview of what the foundation has set up for the genetic testing program. It's intended for people diagnosed with inherited retinal disease. So this is not an exhaustive list, but kind of everything we think about for retinal degenerative diseases: retinitis pigmentosa, LCA, Usher syndrome, Stargardt disease, you know, even retinoschisis. They all qualify for this program. This is not a good program if you have age-related macular degeneration. It does not cover the genes that are being studied that could contribute to age-related macular degeneration. But if you have a younger type of macular dystrophy, that would qualify as well. And that's as diagnosed by your retina doctor. So really, it's your retina doctor determining if you might be a good fit for testing. You do have to live in the United States right now. And like Richard mentioned, it's intended for people that have not already had a genetic test since 2016, a larger genetic test. The reason they set it at about 31 or 32 genes or more is that if you had the genetic test through the Spark Therapeutics program a couple years back, that panel included 31 genes. So it was a good test, but it wasn't considered a broad genetic test. So if you've had a large test, though, we don't think that redoing the test right now is likely to give you much more information. As far as how to have the test ordered for you, it does need to be ordered through your healthcare provider. Most people go through their retina specialist or an interested ophthalmologist. As of last fall, they expanded this program to be an open access program. So that means that more doctors are able to order the test. So there's actually information on the Fighting Blindness website for providers as well who may not be familiar, to kind of walk them through the steps of ordering the test if they're not familiar. And I know Dr. Mathias and Dr. Kimura are pros at ordering this test. They've been involved for a lot longer, so they would be good resources as well. When your doctor orders the test, then they have the option as to if they want to provide counseling about the results, or if there's a genetic counselor in that clinic that can counsel about the results, or there's a checkbox where they can where the results can be delivered by Inform DNA, which is myself and about 4 other genetic counselors for this program. And so that genetic counseling, if it's through this program, is included in the cost. There's no separate cost for that. So we recommend you take advantage of that. It is ultimately up to you, but we recommend it. It's included. And that's all over the phone. So that, again, can be set up pretty conveniently when you're at home. As part of the program, we really do encourage everyone to enroll in the My Retina Tracker registry. That's where you can add your genetic information so that the foundation knows about your gene and can contact you about potential clinical trials. It's not for sure required, but we encourage everyone to enroll. And again, for this program, if you get genetically tested this way, there's no cost to you, and you don't even have to involve your insurance company, which is huge. If anyone has tried to go through genetic testing through your insurance company in the past, it's there's quite a few hurdles, so it's nice to leave them out of it.
That was excellent, Kelsey. Thank you so much. And I'll just add to that being in my retina tracker, I heard yesterday in our national call that we have over 16,000 people in our registry right now where we have their gene information. And what's good about that is we have a lot of biopharmaceutical companies like Applied Genetics Technology Corporation that are looking for patients. And they will contact us saying, who do you know that has XLRP and the RPGR or whatever the case might be? And then, of course, it's all, confidential information. So we'll share that request with the people who are signed up as patients in our MyRetina Tracker system to let them know, here's an opportunity for you to get involved in a clinical trial. Would you like to do that? And then it's your choice to contact them. Great. What's the next question, Chris?
The next question, there's a lot of hope around the studies and the estimation of time that everything, from a treatment perspective. But I think, this may be a difficult question to ask, but how long do you feel on average with stem cells therapies, how long before they become a standard treatment?
Yeah, I'll take that. I mean, it's certainly definitely a difficult question to answer. There are so many different groups, which is good, working on stem cell regeneration in so many different ways. There are many different, like I was kind of reviewing, there's lots of different ways to get the stem cells in the eye and that sort of thing. But the good news is there are several of those companies that I think are, ways along, whether that ultimately shows to be, the way that, that has the best outcome in terms of vision and that sort of thing is hard to know. But, certainly when we look at something like retinitis pigmentosa, the two companies in the US are definitely moving along, and one of them, J-Site, is moving towards a phase 3 study. So and they've had some encouraging results in their phase 2 studies, and if those companies if those technologies prove beneficial and they submit to the FDA and it shows improvement enough in terms of their outcome measures that it gets approved, that those certainly are something that could be seen within a few years. Some of the other groups that are looking in different ways that are still in preclinical studies, I think that those things are further away and probably more than 5 years in terms of really developing that sort of technology. So it's a little hard to answer, but there are a few companies that, are doing, stem cells in a way that might give them the ability to have, a product that works within 3 to 5 years.
Yep. I would just want to add to that, Dr. Matthias, to say that I'm actually involved in the J-Site stem cell trial. And what's complicated is this COVID virus situation, because they've asked me to come back for a final checkup. There's many reasons around that, but I'm just not willing to fly right now. I'm sorry. So I told them, because it's in Orange County, UC Irvine. So, that's complicating the situation. But as Dr. Matthias shared, they've had both the intravitreal injection of the stem cells, which is the J-Site trial, has had about a 2-line improvement in vision on the average in their first few phases of the trial, and the one in Renuron in Boston that's in the subretinal injection has had about the same 2-line improvement, maybe a little bit more in some cases. So anyway, it's showing very, very good promise. And like you said, it probably is 3 to 5 years out before that gets through phase 3 and gets the FDA to approve it. Anything you want to add to that, Dr. Kimura?
Yeah, I mean, it's as Yogi Berra said, predictions are really hard, especially if it's about the future. So these are still early days. As much as we want this and see this as the potential holy grail, It's early days, right? So, just regular chemistry, the drugs that that people take, well, there's been decades on that, right? Now I've got gene therapy. Well, we're still learning massively about that. And I think the new kid on the block is our stem cells. So we're still very early days, right? This idea of we're going to replace it and everything's going to be good. Well, that was certainly a bit, hopeful and naive. And we're discovering new things. You don't necessarily have to replace that whole tissue, like in the J site. You can just put progenitor cells in there and spitting out their little chemicals called cytokines. They may keep cells that are on a pathway to dying, keep them alive. Second one is when you try to put them under the retina, as Mark said, the RPE is this phenomenally complicated and specialized tissue that's one cell layer thick. So, right, first attempt, squirt a suspension in there, right? They'll all just fall in the right place. Well, probably doesn't happen. So that's why they're working on, as Mark said, you may need to have a sheet. So it may be like a layer cake where the cells, the RPE is oriented to face to the photoreceptors, and then maybe beneath it for the choroid. So you may need to be thinking of a neighborhood effect of a number of cells, not just squirting in that cell and then we're done. So again, early days, the talks that you're going to hear in the next decade are going to sound very different from what we're doing today, which is great.
What's exciting is we have so many trials underway, and there's just not one approach. There's many different approaches that are being done. That's what's important. When you support the Foundation Fighting Blindness and our research programs, you're funding a myriad of projects, 80 different projects, because we don't know which one's going to be, as Dr. Kimura says, the Holy Grail. So anyway, we're hoping all of them will be successful, but we know in reality that doesn't happen that way. So Chris, I know we have many more questions and probably about 5 more minutes that we'll spend on these questions. And if we don't get to your question, we will get back to you with an answer very soon. Okay, Chris?
Thanks, Richard. There are a few questions in regard to vitamins, supplements, dietary restrictions, needs. So for the first one, is can AREDS 2 or any other vitamin help RP in any way?
Dr. Mathias?
Yeah, I mean, I don't think there's enough information on that. We just don't have a large study. There's certainly not a lot of harm in that. And I certainly know some other inherited retinal disease specialists would like to have their, some of their patients on lutein or sometime an AREDS 2 supplement. The one vitamin that's really been studied the most is high dose vitamin A, which is, significantly higher than what's in the AREDS dose. It's 15,000 international units. And that was born out of studies that were funded actually through the Foundation Fighting Blindness starting in the early 90s and through the 2000s. And, the data on that has been argued back and forth between, inherited retinal disease specialists over the years, and some patients or some providers are advocates of it and others aren't. There may have been a mild improvement in some studies or in some of the studies that in terms of the visual field, but it wasn't really clear, and the data analysis wasn't really clear. But I'm not going to get on here and tell you to take vitamin A or not. But I think that's a good discussion with your inherited, whoever kind of you follow with. Because there are some side effects with it potentially, but beyond that, I think particularly with AREDS, there's nothing clear that we know with AREDS 2. I always encourage my patients certainly to live a healthy life as much as they can, good exercise and a healthy diet that is less inflammatory, which tends to be less processed foods, less red meats, and more fresh fruits and vegetables and fish. And more of like a Mediterranean style diet. But again, we don't have large data on that. But certainly, there's good data in terms of potentially things like macular degeneration and things like that, that there may be certainly lower amounts of inflammation within the body, and that may contribute ultimately to lower cell damage when you have some sort of degenerative disease like retinal degeneration. But I'll say that. I don't know if Alan has any further comments.
Let me ask Dr. Holloman, do you have any thoughts on this?
I mean, I've seen some of the research around, high dose vitamin A, but I haven't heard much about any research around AREDS2, no.
Okay. Dr. Kimura, anything you want to add?
Yeah, I mean, so we're in three hats. First hat is, the pure science hat. I mean, the AREDS2 age-rated IZ study 2 was designed specifically to answer a question of progression of macular degeneration. So it wasn't designed to address any of the IRDs. Now I'm wearing the hat of the doc. Well, I got a patient in front of me, and they're, they're asking me this question. It's everything that Mark said I would answer. It's the healthy lifestyle. Now I'm wearing the hat of the patient. Well, like, hey, there's only one FDA approved treatment here. What am I going to do? So the answer kind of looks differently depending what hat you're wearing. But again, the AREDS2 was designed to answer the question of progression of age-related macular degeneration, not any of the IRDs. So we don't have evidence.
Yeah, the dry form, right? It was targeted for the dry form of AMD. Okay, what else we got, Chris? How about 4 more minutes?
Well, along with that one, it's, on the flip side, you were talking about vitamin A especially, and then the question about Stargardt. Because I know that there have been conversations about limiting the amount of supplements with vitamin A with Stargardt. But are there also any dietary restrictions that people should keep in mind?
Dr. Kimura, you want to start?
Yeah, so great question. So as Mark talked about on the Stargardts.
Dr. Kimura, you're muted.
Oh, no, I don't think so.
No, I can hear him.
Yeah. Can everyone hear me? I hope. Yeah.
I can hear
you.
The vitamin A is part of the visual cycle that we all use to see. Those molecules can sometimes form these toxic kind of aggregates, twins, these dimers. So there's different strategies. One, to slow down the visual cycle so you generate less of those vitamin A dimers, or to use, again, the deuterated, this other form, so it kind of doesn't generate the toxic stuff. So it kind of makes sense that you wouldn't want to feed more into the hopper upstream to drive more vitamin A through this toxic cycle. The other question is, well, what do you do just regular diet in life? I don't know, Mark, if you're aware of any thing where you deliberately try to avoid foods that have vitamin A. I'm not aware of any studies or evidence.
I generally tell people, I say, look, vitamin A deficiency is an issue, right? Vitamin A deficiency causes vision loss. Your eye needs vitamin A to be able to see. Through your normal dietary intake, you're really not taking excess amounts of vitamin A that, are really likely to, in my opinion, drive progression of Stargardt. I think it just comes into play when you're talking about taking really high, potentially much higher doses than you'd be able to obtain within your diet by a vitamin supplement. So I generally don't discourage people from dietary vitamin A, because I worry about the flip side, that they're actually going to get vitamin A deficient, and that could, potentially have harm to their vision as well. So I generally don't have a particular Stargardt diet that I recommend to patients, other than what I just kind of mentioned with retinitis pigmentosa, macular degeneration, just inherited retinal disease in general, overall. So.
Wow, well, this is great. What a lot of great questions. And I know we probably have a few more, but we've run out of time this session. So like I said, you can continue sending your questions to denver@blindness.org, and we will get back to you with the answers on those questions early next week. Thank you so much for all the great questions. I really appreciate your participation. Now we're going to pivot, take a 5-minute break, and set up the panelists for the low vision services and adaptive technology and all the things that you need as far as orientation and mobility. Go ahead and send in your questions for that, because they'll be presenting themselves, and then we'll be able to have a discussion with them about the services they provide and how you might take advantage of those services. So be back at 11:40. See you in a few minutes.
We are back on.
All right. Welcome back, everybody. Great. I hope you've been enjoying this presentation, a research update, and all the great questions that came in about the different diseases, genetic testing, and everything. Now we're going to pivot to the low vision services, the people and organizations that are in Colorado, and they're actually in most of the major cities around the country that provide these types of low vision services that can help a person that is trying to adapt to low vision or blindness, orientation and mobility, maybe getting their home set up to be able to use it for in a blind situation where, you know, the lighting, buttons, I mean, there's all sorts of things that we deal with as blind folks. And then also the technology, how to your iPhone, your JAWS, computer, Zoom text, all of those different issues. That's what we'll be talking about right now. So without further ado, I'd like to introduce Shirley Prop with Audio Information Network to share a little bit about who they are, and then we'll introduce all 8 of these before we start answering the questions. Shirley.
Hi, everybody. It's Shirley Propey with Audio Information Network. Audio Information Network provides access to over 200 publications. Sorry, I'm trying to multitask and share my screen and do all that, and I'm not doing a very good job. There we go. So we do provide access to over 200 publications in an audio format for individuals that are blind, visually impaired, print disabled, or physically not able to read. We do serve the entire state of Colorado, and we serve all ages. We really do envision a future where everyone has access to all the news and information that they want to see. And you know, we do a lot of different local newspaper stories. We read magazines. We have educational materials that we read, community newsletters, grocery store ads, transportation information, employment information, health tips. We have a growing selection of podcasts that we read. We do read live broadcasts 24 hours a day, 7 days a week in English and Spanish. So there's a multitude of ways that individuals can access our programming. You can certainly use your computer and go to our website, access it that way. We do have smart speakers that we can provide so that you can access it using Alexa. You can use, you know, your computer. You can use our toll-free phone system. We have Wi-Fi radios that we can provide, or digital receivers as well. So lots of different programming, lots of information for people. We do make our content listener driven, so we're always reaching out to our listeners, wanting to make sure that what we're providing to you is programming that you're interested in hearing. And we do this all free of charge.
Great, thanks, Shirley. All right, great presentation. All right, now the Center for People with Disabilities, Melanie Shotwell.
Okay. Hello. How do I share my screen? Oh, there we go. Okay, so I'm gonna share my screen now. Do this, hopefully. Popping up, there we go, and let me do.
Okay, now it says we're viewing your screen.
Okay, there we are. Okay, so I'm Melanie with the Center for People with Disabilities, and I'm in the low vision, I work in the low vision program, and it's called the Beyond Vision program. And the goal of the Beyond Vision program is to help people in our community with vision impairment or blindness achieve and maintain independence. And we do this by providing educational peer support groups, assistive technology and independent living skills training, and along with other core services like advocating and information and referral. And we provide services in Adams County, Arapahoe, Boulder, Broomfield, Denver, Jefferson, Gilpin, Weld, and Clear Creek County. So we're in a lot of places. And right now we have offices in Boulder, Longmont, and Thornton. So we are currently not in those offices. Everybody is working from home. And we are just now starting, we may be pulling back on that. We have been going to meet with consumers mostly in public places, 6 feet apart, wearing masks, but that may be changing due to the increase of COVID cases again in Colorado. So it's kind of going on a daily, we have to watch what's going on. We have grant funding for purchasing assistive technology through the DRCOG grant that we received. And this is mostly like for handheld magnifiers, lamps, any kind of lighting that we can help you with, different resources like that. And we also have a orientation and mobility specialist that we're working with. Of course, right now she can't go into people's homes, but she is doing once a month, she's holding a workshop with our consumers that we're doing over Zoom. Our services are at no cost to consumers, and thanks to a variety of funding services like your local area agency on aging. All right, thank you.
All right, thank you, Melanie, for your introduction to CPWD. All right, Colorado Center for the Blind, Julie Deaton.
All right, good morning, everybody. So nice to be here today with you all, and I want to thank Richard and all of you for having us today. The tagline of the National Federation of the Blind is "Live the Life You Want." And we believe really strongly with the National Federation of the Blind and the Colorado Center for the Blind that even if you are losing your vision, if you are a blind person, that you can completely live the life that you want. Now, you're not going to be able to figure it out immediately. You're losing vision. You're not sure what to do. It can be very, very frustrating, very difficult at the beginning. But there are so many services out there that you can obtain to know that you can gain full belief in yourself as a blind person. The Colorado Center for the Blind has been around since 1988, and we provide services to people of all ages, from the really small little kids and to our senior population as well. We really focus on having that positive belief in blindness. So we provide services at our Colorado Center for the Blind, which is located in Littleton, Colorado. And we also provide services to people all over the Denver metro area and around the state too. There's nothing more fun than working with people who come on into this center and they don't really believe that they can do very much. They don't have any confidence in themselves. They're pretty lost. And then at the end of a program, they gain that belief in themselves and they're using a cane and they're feeling comfortable with being blind. They're living independently. They have their own place to live. They're getting jobs and they're fully doing what they like to do. So we provide Braille, computer technology training, orientation and mobility training, home management training. We are going to people's homes to work with them as well. And we are also providing face-to-face services with our adult students in our independence training program at this center. We do serve people from all over the state, as I mentioned, but also all over the country. So it's a lot of fun. So our tagline at the Colorado Center for the Blind is "Take charge with confidence and self-reliance." Thank you very much.
All right, Julie, thank you very much for your presentation. And Dan, thanks for supporting her on that. Now we have the Colorado Department of Vocational Rehabilitation, Laverne Dell.
Hello, thank you, Richard. I'm Laverne Dell with the Division of Vocational Rehabilitation Blind and Low Vision Services Unit. And there we go. I think we might, there we go. I think we got it. So the Division of Vocational Rehabilitation is housed within the Department of Labor and Employment. And we believe individuals with disabilities are essential to the workforce and communities throughout Colorado. We work with individuals to gain employment, and it starts with meeting with the counselor to do an intake. The counselor will gather information, both medical and information from the individual, make an eligibility determination, and then work with the individual to determine a suitable vocational goal. Once the goal is determined, we put together a plan for employment, and we provide services such as vocational guidance and counseling, blind and low vision services, mental health services, job seeking services, job placement services, and other services that the individual may need to gain employment. Some of these services may cost the individual. It depends on the financial status of the individual. We do run what's called a financial needs analysis to make that determination. However, many of our services are at no cost to the individual. We are a federally and state funded program. And if you would like to connect with us, you can do that through my email address. And I will get that to Richard to get out to folks, and or through our website. Thank you very much.
All right, thank you, Laverne. All right, great presentation. Now let's move on to Colorado Retina Associates, Jalaya Alexander.
Hi everyone. So my name is Jalaya, or you can call me Jay. I'm trying to share my screen, but I don't know if I can at the moment.
Laverne, you would have to, Laverne needs to
Yeah, Laverne,
stop
take
sharing
yours
first.
down. Yeah.
There we go.
Thank you. So I am with Colorado Retina Associates with Dr. Alan Kimura. I am his genetic coordinator as well as his primary scribe. So I float in and out of clinic. In terms of Colorado Retina, it is a we have 13 retinal specialists that focus on different different retinal diseases such as macular degeneration, diabetic retinopathy, retinal detachment, Stargardt's, retinitis pigmentosa, uveitis, inflammation, and tumors, and much, much more. In terms of the genetic department, we try to do the critical connections of care. We want to make sure that we provide you with all the services and any of the services offered. So typically we start with seeing you guys in clinic. So to evaluate and diagnose you, if we can, we do iLab testing, which means we can do ERGs and visual fields. Our visual fields are on the machine digitally and through the Octopus 900, so we can do both static and kinetic. If you are eligible, we can initiate you for genetic testing, which is through what Kelsey was talking about with the MyRetina tracker, and then we try to refer you over to genetic tests or genetic counseling to understand your results through Informed DNA. We will provide you with community resources, including information about FFB, Insight Skills Center, and much more. Finally, we try to get you into a clinical trial if we can. As we saw Dr. Mathias's presentation, they're working on it. So if you have any questions, feel free to reach out to me, and I'll see you guys in clinic.
All right, Jay, thank you. Thank you. Thank you, Dr. Kimura and Colorado Retina Associates. You guys have been great sponsors of the Foundation Fighting Blindness for 15 years. Thank you. Thank you so much. All right, now we have Insight Skills Center, Melody Bettenhausen.
Sure, and I think I actually unmuted myself this time. Hello, everybody. I'm Melody with the Insight Skills Center and Curtis Strong Center for Low Vision Rehabilitation. I do believe that Denny Moyer, our president and CEO, is sitting in on this call. So just throwing that out there. I'm not going to have her chime in. It is the mission of Insight to provide people with low vision tools, counseling, and training that empowers independent living. That's really our main focus. We're very occupational therapy heavy. We work with optometrists, but we also provide all of the additional skills as well. Optometry and occupational therapy are the core, but we also do assistive technology, orientation, mobility training, counseling. We're doing 2 weeks, every 2 weeks we have support groups that are running online where we are getting people from all over Colorado for the first time ever. So that's really exciting. If anybody on this call is interested, I do believe my email is melody@insightskills.org, and I did put it on this slide. We'd love to have you join. We serve the entire state of Colorado. We serve people of all ages. The primary individuals that do come to see us are individuals with age-related eye diseases, but we have individuals who have come with head trauma, with juvenile onset forms of diseases, Stargardt's, retinitis pigmentosus. So we are a comprehensive center. We work with you to provide you with the skills that you need to be independent, and that really is our main focus. Our headquarters is in Fort Collins. We also have a clinic in Greeley, Colorado as the Curtis Strong Center. And then we are working in Lowry at Colorado Retina Associates. And we've got a few other satellite offices throughout the Denver area to best serve that clientele. I just want to throw out one last thing is that we've got really diversified funding. So it's really important for people to understand if they're currently undergoing occupational therapy and they're holding off on our services because of that conflict, we have ways around that with the wonderful funding through Dr. Cog, through the Older Individuals Who Are Blind program. So don't hesitate to reach out and see how you can get involved with our services.
Thank you, Melody. Great presentation. I know Melody and Danny well. Great job. All right, now we'll go to Joseph Wheaton with Techie Joe Computer Solutions.
Hi, everybody. Joseph Wheaton here. So I'm going to go ahead and share my screen here for you. And there we go. How's that? Okay. So just wanted to thank FFB and Richard, all the folks over there for giving us a chance to kind of just present to you guys here a little bit. As many of you may know, we're basically, Techie Joe's is a team of trainers, technology trainers. We specialize in assistive technology. Really our goal is to be able to kind of work with folks one-on-one and be able to help you guys with all these different areas. I kind of put together on this slide, as you can see, there's a lot of different areas here that we tried to highlight for you, but basically includes technology items like PC computers. We work with folks on Apple computer platform as well. Also work with all the different Apple products like the iPads, the iPhones, your Apple VoiceOver for speech output. Working with the accessible apps as well. We've got a whole list of those. We'd love to share with you and help recommend those. The JAWS screen reader, as most of you are familiar with, for just reading everything on your screen and really being able to allow you to access your whole computer system. Things like Zoom Text for magnification, also reader tools there too. We work with the Google applications now as well, so that's something new that a lot of folks are really learning to use with their screen readers, with magnifiers, with speech and things. There's a lot of wonderful tools there that are free to you that it would be great to take advantage of. Working with things like your Microsoft Office, training you on things like your Outlook and using the email tools efficiently there. Any webmail applications with your assistive technology. The guide software suite, which is helpful as well for large print. It also reads things to you and is very easy to learn and use. Things with the Android as well for those smartphones. Windows accessibility, just kind of showing you what's available to you already within Windows 10. There's a lot of great tools there for accessibility, for magnification, for reading, for high contrast. You got large mouse pointers, all kinds of things you can do to just adjust what you already have. The Windows speech recognition is another area too that we work with. And of course, Dragon Naturally Speaking being probably the most popular product for that. But we like to just let you guys know that we have a whole team of folks that can kind of come out to you, work with you either remotely, which is what we're doing with most folks now. But we can also work with you in home if you feel comfortable doing that, and it's a good setup for you. We try to work with you guys one-on-one with those things. So, and then let me switch over here, slide number 2. We wanted to let you guys know that kind of the 3 main areas we're working with is like, evaluation, just evaluating what's, most appropriate for your technology, helping you be able to kind of see what's available, and then also be able to, really put together like what would be most appropriate for what your goals are and what you're trying to accomplish. We're offering a free 1-hour evaluation for private pay individuals via the phone. If you'd like to contact us, we'd love to be able to chat with you for a while and kind of see if we can put together some different ideas for what would be most appropriate for you, what's available out there, and talk to you more about our services. And then for the technical and troubleshooting, we like to let you know that we can troubleshoot a lot of different assistive technology areas, do some repair, setup, customizing that technology for you, and of course, working with you remotely on a lot of those different things. The one-on-one training sessions, as I mentioned as well, is kind of what we try to specialize in too, to be able to help you guys really be able to understand your technology and use it for your independence. And then we provide things like step-by-step instructions, helpful keyboard shortcuts and commands and things that'll help you be able to work with those applications more efficiently. We also provide reference material if that's available, either from the manufacturer, or we may have put together some of our own that we feel is really helpful for folks to be able to refer to with these different programs and applications. So yeah, feel free to contact us by phone. We got our number here, and also email at info@techiejoes.com, or you can reach us here by phone. Also through our web, you can also send us a question through there, or just submit your information and let us know what we can help you with. So thank you.
Thank you, Joe. That's great. Wow, what a comprehensive review. And I can testify to the fact that I've had Joe in my home 3 or 4 times, and he's given me excellent instruction on how to use my JAWS and even iPhone. So, I mean, he's really, really experienced and has a great team. Thank you, Joe.
Thank you.
All right.
Pleasure.
Next, we have Samantha Miller with Tides Changing Therapies, our last panelist here. Introduction.
Good morning, everybody. I have shared my screen. I am Samantha Miller. I am a licensed clinical social worker. For those that that acronym doesn't ring a bell, that means that I am the typical therapist that you see on a movie or read about in a book. The therapist is on the chair and then the client is on the couch. That's what I do. So I do the one-on-one therapy with people. And as you guys know, there are therapists that specialize in so many different things. Like there are eating disorder therapists, but you think about low vision, and hearing about a low vision therapist isn't really known. And so that's where I come in. And my goal in life is to bridge the gap between mental health with people with low vision and blindness. So prior to moving to Denver last year and opening up my private practice, I worked at the Tampa Lighthouse for the Blind in Tampa, Florida, where I was the social worker, the counselor, the individual counselor, the group counselor, the family counselor. And that's where I really honed in on my niche of working with people with low vision. And I believe that mental health is important for everyone. And so I'm a huge mental health advocate for everyone on this earth. But people with low vision, it's a specialty. And it's clear that vision loss is consistently associated with higher levels of anxiety and depression. And it increases the likelihood for social isolation. And there are things that you could work with a therapist to help kind of ease that transition if vision loss is new for you, or if you've had a change in your life. So what I do is I do the individual counseling. And the beauty of technology is that we are able to do that online. So I also have an office in the Denver Tech Center for anyone who is local to the Denver area. But if not, I do therapy online. And if you aren't familiar with it, you basically use a telehealth it's like Zoom, but it's HIPAA compliant. So it's like a safe space where you can meet with a therapist. And I do that. And I like to focus on coping, anxiety, depression, and also grief and loss counseling. When you hear grief and loss counseling, oftentimes people think like death of a loved one, where I'm obviously focusing on the loss of vision and the grief that comes with that. So that's the kind of counseling that I do. And that being said, I love to inform people about mental health. So I'm available for educational seminars or running a support group, things like that. I've done that for a few people on this call, so that's been really nice. Yeah, and I offer a free 15-minute consultation just to talk to people about mental health in general, to see if we could be a good fit, and if not, to see if I could find a counselor or a therapist for you, because I understand it can be very difficult for everyone, sighted or not, to find a therapist that meshes with them. So my email is samantha@tideschangingtherapy.com, or you could just go to tideschangingtherapy.com and visit my website. I'm also on Instagram, Tides Changing Therapy. Thank you so much for having me, and I hope everyone takes care of their mental health. Thank you.
Thank you, Samantha. Wow, yeah, we got a very powerful group of 8 panelists here. So I hope there's a lot of questions that have come in, and we'll see what we can do to direct them. I will try and direct them to at least one of you, and then maybe I'll have one other speak to one question so we can try and get through as many as we can. Okay, Tris, what questions do we have?
So we have one question that has come in for the panel. Is there a low vision or blind ballot for the November election?
Oh boy, is that Julie? Would you know that one?
We can answer that question. Dan could jump in if he wanted to. My husband's here because he really worked hard. So yes, you can actually vote online now. You do have to print out your ballot, but you go through the Secretaries of State's office. Dan, what's the link for that?
myballot.sos.colorado.gov.
So you can vote privately in your home just like anyone else would. I've done it. It's very easy to do. So you can also go to polling places and utilize the voting machine that's audible, and that's very easy to use as well.
All right, does anybody, who else might have anything to add to that? Anybody? Okay, all right, Chris, what else?
Those are the questions that we have right now. Again, if you have a question for any of our panelists, you can use the Q&A or chat features within Zoom.
Or if you want to raise their hand, can you identify somebody by the raising of their hand? Is that possible?
No hands raised at the moment. Yep, no hands raised at the moment.
Okay, if you raise your hand, Chris will unmute you so you can ask your question.
I have one question. I have an Amigo and a Pebble digital handheld magnifier. Is there a way to sell these, or if not, can I donate? And to which organizations?
Let's see. Who would handle something like that? I'm not sure.
Mute. Hi, this is Julie from the Colorado Center for the Blind, and we definitely take donations and then we redistribute what's donated to people that really need them in the community. So you can give us a call and we can do that. We're more than happy to do that and make sure that somebody that really needs this equipment can get it.
Okay, great. Thanks, Julie. Anybody else? I know Insight takes donations of equipment as well and provides them to people who might need them. Anybody else? Okay, Chris, any more questions? I heard something come in.
Yes, we have Andre Van Hall has raised their hand and has a question.
Andre, good to see you today.
Well, thank you. You already read my question. That was the, so thank you very much.
Okay, good. All right, any other raised hands or questions for these panelists?
Yes, there is a question for Samantha. Are your services available in states outside of Colorado?
Thank you. That's a great question. Yes, the services are available. Obviously, it's only online. I'm not traveling to different states. But yes, online services are available. However, the client has to know that they are signing a telehealth agreement that basically says you are coming to my state of licensure. Every state has different rules. I think it's silly. Why can't I be a social worker in Nevada if I can do it here? But basically, it says that you travel to my state, so you have to follow my rules, which are not that different from other states.
Great, and I think Samantha, you'd be willing, if there was somebody quite a ways away, you'd be willing to maybe find share a therapist maybe in that area?
Yes, yes, and that's one of the things that I love to do with anyone that's looking for mental health services. I'd love to tell people how they can find services and make that accessible to them if they wanted to see somebody in their area or online.
Great, 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 thank you.
Of
All right,
course.
I heard Andrea Lowry. Raised hand?
And lowered.
Sorry, that was me. This is Joe Lowry.
Oh,
Hi, Richard.
oh, okay, well, you're not as good looking as Andrea.
No, she was on the call earlier, but she had to go to a different call.
Okay.
Does anybody know how to fit an Ambutech tip to the end of a Revolution cane? I really like this one Ambutech tip that I'd like to try, but I have a Revolution cane. And what do you think about the difference between Ambutech and Revolution? I haven't used a Revolution. I mean, I have not used an Ambutech cane. Are they good?
Who can answer that one? Nobody?
I don't know. Did Melody call? Is Melody still online from Insight?
I can't answer that question myself. I'm pretty removed from the orientation mobility knowledge, unfortunately. Denny, do you have any ideas?
Well, she's muted probably.
Yeah, she is muted.
Laverne, do you at DVR, do you have anything access to that type of cane, fixing canes or stuff?
Our orientation and mobility specialist would, but I couldn't speak to the specific tip fitting to a specific kind of cane.
Okay, no problem. What we'll do, Joe, is we'll make a note of that question and I will get to someone that I know could give you an answer to that question. Okay?
Okay, thanks.
I'll take care of that.
Maybe
Denny,
I'll end up,
you want to unmute Denny if she has any thoughts?
I might end up 3D printing an adapter to put an Ambutech tip on the end of a Revolution cane. If that is successful, I'll let you know.
Okay, very good, Joe.
If I might weigh in for just a second here, Richard,
yeah, Joe, sure.
Don't have experience with the canes other than just assisting people with ordering them. But I can say that there are quite a few online resources, places like Amazon that you can go to be able to order different accessories like that, like different tips to your cane or different canes. And I have assisted quite a few folks with getting on there and doing those orders and figuring out, the length of the cane, how many breaks or, how it folds and things like that, depending on which style you want or which model you want. So there's a lot available online. I wanted to mention that to folks as a resource for you. You might find a different tip on there that perhaps fits your cane that you didn't even know was available for your cane.
All
Okay,
right,
cool.
good. And I'll try and get him connecting with Scott at Beyond Sight. I presume he's still around. I haven't talked to him in a while. They used to handle that stuff directly at the Beyond Sight store. So we'll see if he is still connected with that. All right. What other questions?
So we have, I think this question is for Laverne. Laverne, it seems to be a big difference between the Denver location versus some of the other locations that DVR manages. Seems that the Denver location has a lot more training classes versus others. Is that true?
It's like any large city. You're going to have more services in the larger city. We do have services across the state, but we do not have centers across the state. We do have the independent living centers that folks can access services through, however, like Insight Skills Center, Center for People with Disabilities. There's the, I'm forgetting the name of it. There's a Southern independent living center down in the southern part of the state. So we do have different options, and each service provider looks a little different.
Great, great. Let me ask a question to Melanie Shotwell. I'm a new, I think some people might have this out there, and or maybe they're all, you know, sophisticated already, but I'm losing my vision, and I'm having trouble getting around. I'm not sure I want to use a white cane, and I'm trying to figure out what to do about that. Melanie, how would you help somebody like that?
Probably it would just kind of depend. Person would call in and ask us for advice, and probably the best thing that we would do for them is refer that person to our orientation and mobility specialist, and she would give them a call and talk to them about the benefits of using a white cane. If they didn't want to talk to the orientation and mobility specialist, we could just talk to them about why they're feeling hesitant about using the cane. I'm getting a weird thing on my, says the host has asked you to start your video. Oh, do you want to see me? Sorry. Just talk about their feelings about what's maybe holding them back about using the cane. Talk a little bit about the pros and cons of using the cane. Again, if it was kind of going beyond what I felt comfortable with, I would refer them to our O&M specialist and have her take it from there.
Beautiful. Thank you, Melanie. That was great. Yeah, those are all good tips. And I know a lot of people have deal with that transition from where they've been independent and now they're less than independent, and they're having to consider a white cane, and the stigma that many people have in their head about that. It's a true stigma. I have been through it myself. So, but I can just share my opinion is that once you start using a white cane, your life will never be the same, or a guide dog. It just truly makes you independent. You just have to get over that stigma, and trust me, it's the best decision you'll ever make, because it was in my case. So anyway, yeah, and then also one more question is that I used to be able to read the newspaper, and now I can't read the Denver Post anymore. So what do I do about that, Shirley?
You call us. Call Audio Information Network of Colorado. Let me give you our phone number. We are Boulder-based, but we do serve the whole state. You can reach us at 303-786-7777. You want to talk to Matt. He does all of our installations. He's very, very well versed in all of the different ways that there are to access the newspaper. So he'll talk to you about your comfort level. Do you have technology? Do you not have technology? What are you comfortable with using? And then set you up with the right kind of equipment if you need it, or help you get our programming loaded on your smartphone, or get it loaded on your Alexa, whatever way is best going to serve you. Obviously we can't go into folks' homes right now, but Matt's done a great job of setting up some systems in place to help people get the equipment, even though we're not really physically able to go in and set it up for folks. So we'll get you set up. Thanks, Richard.
Great. Thanks, Shirley. And thanks, Chris, for posting the phone number for everybody.
Richard, this is Julie. Can I also say audio information services is amazing, but there is also another thing available too to complement audio information services, and that's FFB Newsline. And so you can access a lot of papers within the state of Colorado and publications from all over the country through your phone, your iPhone, through a regular phone. You can read it on a display. So that's just one other resource as well.
What was the resource again?
It's called FFB Newsline.
Oh, NFB, no, National Federation of the Blind Newsline. Okay, NFB Newsline.
Totally free service.
Okay, good, good. Thank you for sharing that. Chris, what other questions do we have?
This one is actually, there's two in for Julie around vocational rehab services around the Colorado Center for the Blind. Are the services covered by the state, or do you need a referral? You know, some folks are wondering if you're funded or have grants to be able to cover services.
Thank you. That's a very, very good question. We work really closely with the Colorado Division of Vocational Rehabilitation. And so much of our funding does come from Colorado DVR for students that attend our program in our adult independence training program. And so when you would call our office at 303-778-1130, we will ask you, are you currently working with Colorado DVR? And if you're not, we'll go ahead and get you referred to them, and I'll work closely with you if you're interested in coming into training to make sure that everything can fall into place for you. We do have our senior program though also, and we have a grant for people that are 50 and over right now. It's crazy to think seniors could be considered 50 years old, but we do have a grant. And so a lot of our services for people that are 50 or older are covered through several different grants that we have. So we have a couple different options.
All right.
If it's
Great.
okay, Insight was included in that question about services and fees. Is it okay if I answer that real quick?
Sure.
So Insight does provide throughout the state services, and we do have a lot of really good funding in multiple counties, including the entire, 8-county region of Denver, Larimer County, Weld County, and some additional counties out there in the rural areas. So we do have abilities to provide funding for individuals. A majority of it is 55 and older, like Julie stated. But then we also take insurance, and we have some other really good programs. So I just wanted to throw that out to people.
Sure. No. In fact, I was going to throw something your way, actually. So, Chris, anything else, or maybe one more question?
Go ahead with your question, Richard.
Yeah, I was going to say, Melody, I was going to ask you, say, hey, I'm 70 years old, and I've got macular degeneration, and I'm losing my vision, and I'm struggling to get around in my home and get to the doctor, etc. How can you help me?
We do, again, we have our on-site programs, which try to come as close to people as possible. Right now, with all the COVID restrictions, we're starting to get back into a lot of the in-home training with occupational therapists and orientation mobility. We're also able to do telehealth while we're trying to navigate some of that if people are concerned about coming into the homes. So we do that in-home training. We do that in-work training and that volunteer place training. So we've got the full team to help you with that.
Fantastic. Well, great. Does anybody have anything else they want to share real quick before we close this session?
Richard, I have a quick question.
Yeah.
I'm personally new at this because something came down on me like a ton of bricks right at the end of March. I took a full course of O&M training, but you mentioned earlier that you won't fly right now. What about Uber and Lyft? Do you trust them right now?
That's a really, really good question. I think that's a personal choice. You have a choice between independence and walking. So I think if you make sure they wear a mask and you wear a mask, I think you probably are safe. Has anybody been riding with Uber or Lyft? What I haven't done one since it started. I've been in Southern Colorado, and they don't have it down here where I'm at. So has anybody been riding an Uber or Lyft, and how's that gone?
I'm sorry. I just know for Uber, it is required that you have to wear a mask. They've made that a policy. So
this is Julie and Dan, and we've ridden in a couple. We were using them a lot more before all this, and they do often have the windows open, and we have our masks on, and I felt pretty good, but not as comfortable as prior, to the COVID and all. We do take the bus a lot, and I get a little nervous sometimes on the bus too, because you don't even know for sure if everybody has a mask on. But I feel like buses are big, so hopefully people are kind of spread out at least. But it is definitely something, like you were saying, Richard, like has to be a personal choice, I think. We do walk a lot more. That's true.
It is a very, very good question. Yeah, it is. I think it's a personal decision, and I think it depends on your health. If you have any kind of comorbidities or issues with your health, I would probably not. I would not test it out. So that's just my feeling. But you know, it's a personal decision. So what we'll do is we'll wrap this session up. Thank all of you very much for your very, very great participation and support for this. And we have one final session that we will just move right into, which will be local Denver, Colorado events. And Lindsay, are you on our call right now?
I am.
Lindsay, I'll turn it over to you. Lindsay Blankenship, our Colorado chapter president of the Foundation Fighting Blindness. Take it away.
Can everyone see me?
Yes.
Okay. Oh, we just wanted to make sure. Well, hi, everyone. I'm Lindsay Blankenship. I'm the chapter president. And what a wonderful online symposium. I'm highly impressed. So well done, everyone. And I am a new president. I've only been the president since last October. And I myself have RP. And I'm a mom of 2 young boys. And just getting by as much as we can. So I hope everyone is staying well and safe and happy. Our next event actually is Wednesday, and it's the Scramble for Sight, which I will be volunteering at. And this is our 20th anniversary for this golf tournament that Scott Burt and Sherry Grunberg put on. And it's wonderful. And I think so far we've actually already almost raised $80,000, and this goes straight back to the FFB. And I have a feeling we'll reach well over 100 by the end of the day. So that's on Wednesday. And then our vision walk is going to be virtual this year because of COVID, and that will be October 24th. And as we get more information, we will share that with you. And I myself run a support group for the FFB Denver chapter or Colorado chapter, and we do it every Saturday, the last Saturday of every month. In August, we are going to do a Zoom call because I think people are missing that kind of interaction. So we will be doing a Zoom call in August. So that will be August 29th at 9:30 in the morning. And we do that the last Saturday of every month, same time. We used to meet at a natural grocer, but obviously we've had to put that on a hold. So if you're interested in joining my email list, we also do, one of our longtime members, Larry Young, has put together a wonderful list of all services for the low vision and blind. And I'm happy to send that out to you as well. So if you'd like to be on my email list, I do only email probably once a month unless something's coming up. Feel free to email me at lsiegs29@gmail. So lsiegs29@gmail.com. Or you're always welcome to call me at 303-875-7772. And if you ever want to become more involved, please let me know.
Thank you, Lindsay. Yeah, you could also email to denver@blindness.org, the one I gave you earlier. That will get to both Lindsay and I as well, and we can connect you for sure with the support group or any of the events. Now, one thing that with the Microsoft Scramble for Sight next Wednesday, there will be an online auction that I think is already started, and everybody can participate in that and bid on the items that are there. What is the web link to that online auction? Do you know, Lindsay?
I know that it is through Octria, but Richard, I will have to look that up.
I think it's Marguerite, isn't that the to go to the scrambleforsight.org and you'll find it?
Yes.
Yes, it is.
Yeah, it's www.scrambleforsight.org, all small letters, scrambleforsight.org, and you can click on the auction and check out all the different items. I don't know how many they have right now, probably 40 or so, and you can make a bid. And it's one of those that once you make a bid, and you're the high bid, then what it'll do is if somebody bids over you, it'll send you an email and say, you just got outbid. And so that way you can go back and bid again. And so anyway, that's it's kind of a fun thing. It's very easy to do. So you can do it from anywhere around the country. So Wayne, over there in Georgia, you're bound to need some good stuff over there, right, Wayne? So check it out. And so is there any other final questions, Chris, that have come up, popped up anywhere that we need to get back to somebody on?
I think we're good for right now.
All right. Well, thanks everybody for participating in our first virtual symposium. I hope we'll have more face-to-face symposiums in the future. But I think this one hopefully went well for all of you, and I look forward to your feedback. You can certainly email me at denver@blindness.org and let me know your thoughts. Love to hear from you. Thank you for participating and being part of this today. And please stay safe and healthy during this virus situation. Have a great day, and we'll look forward. And we want to thank did our sponsor slide get up yet, Chris? If not, pop up that corporate sponsor slide. We want to thank you for being part of this and thank our sponsors for their participation. Have a great weekend, and we'll see you next time. Bye for now.
Bye.
Bye.